All right, we're now recording.
Okay, perfect. Can you guys hear me okay? Okay, good. I'm just going to see how to minimize this. Okay. So this talk is going to be very informal. So at any point, just stop and ask me questions, and we'll take a couple pause breaks just so you guys can ask what's on your mind. And I did this talk as kind of questions that I might have had as a medical student. I'm going back a ways, but things that I wish someone told me, or I wish advice I had that just kind of is commonplace that I know now that would have gotten me potentially on a different path, or things that really are important to know when you're deciding on your subspecialty, or where you're going to live, or how you're going to spend your time. So without further ado, I'm going to tell you a little bit about experience in private practice and academic medicine. And, I think the answer here is that it's all very gray, because, private practice and academic medicine are not truly, dichotomous areas, and they kind of overlap and blend a lot. And I'll tell you some specific examples of those. So let's see. Okay, so the way this talk is going to go, I'm going to talk a little bit about my background, how I got to where I am now. Then we're going to go into private practice versus academic medicine. And again, I don't have all the answers, but I'll just give you kind of my anecdotal stories of where I've been and some of the things I've heard from colleagues and friends. Talk about my typical work week, talk about compensation structure, and certainly no questions off the board, whatever you want to hear about, because obviously how you get paid and how that comes about is very important to all of us. What my different sources of income are, my recent role and my past role as an administrator of the practice, and then what I kind of lump together is scholarship, both education and then my research endeavors. So start this off right here, and this is what it's all about. This is my family. So that's me, and that's my wife, Tracy. And then I have 3 kids. And, fortunately in this picture, everybody's smiling. Kelsey is on the right, Tyler's on the left, and then Emily, my youngest, is in the middle. And as I go through this talk, and as I was putting this together, I think you have to realize what's important in your life. And the people that are listening to this right now, you will have all the opportunities to do all the professional things that you want to do. You can make your life as busy or as easy as you want, but you have to keep in mind, the family and, the people close to you. You have to make time for them all the time. And in the end, this is what really matters. So I just put my family up here, and, as you're going through this, keep that in mind about, what it's all about for you, and having time for this family and friends is very important. So you jump back here, and I said, oh, let me find a picture of my family. And then you blink, and then this is them very recently in the last few months. And your kids grow up really quick. And, that's time that you don't get back. And everyone says that, but it's really, really important to make time for them, as you're growing your practice and getting involved in research and other things. So this is Emily now, who's 11, Kelsey, who's 17. She's off to go swim at William & Mary in the summer. And then this is my son, who's 15, with his football coach. So time goes fast. They become mini adults before you know it. This is where I grew up. I grew up in the Catskill Mountains. So I grew up about 90 miles north of New York City, in a very, very small town. And my parents were both in education. My mom was a teacher. My dad was a college president. And that's it. That's where I grew up. I grew up with one brother and my parents. And, it was all in front of me. And, I look back at things like this and, where I am now, and I'm appreciative of my parents, and I'm appreciative of the values. And then it's all grown from there. So my path to where I am now started at the College of William and Mary. I wanted to go somewhere warm and I wanted to be able to swim. So I went down there for 4 years, and then I came back up to what at the time was SUNY Health Science Center at Syracuse. It's now since changed its name to Upstate Medical University, one of the state schools in New York. And then I came and matched at Robert Wood Johnson for my orthopedic residency. And I will tell you that in high school and in college and in medical school, I was good. I was never the top. And I mean, obviously you had to do well to get to where you are and to get to the next step. But when you talk about working at your potential, I think I was, average to above average for where I could be. And to me, it was always hard to correlate, studying for the exams and then what you would do later in terms of taking care of patients and, really doing meaningful work. And I want to say that because of, all the students that, you're kind of, going through and you're memorizing and you're working and saying, what's this for? It does make a difference later. And I mean, all that stuff is the knowledge and the foundation that's going to let you be, the superstar physician. So these things happened, and then I ended up at Robert Wood Johnson for my residency. And that was the first time in my life I really saw, the value of what I was doing. I mean, taking care of patients and making decisions, based on, my intellect that really changed the outcomes for the rest of their life. If you screwed up a surgery or you ordered the wrong medication or you didn't put the splint on correctly, I mean, it had real ramifications for their ultimate outcome. And some of these things are things you can't take back, right? If you slept through your compartment check in the middle of the night and that person needs to go to the operating room, there could be some catastrophic complications. So for me, as soon as I got in that position, I think that's when I really took off, because I could see why it was so important to read, why it was so important to, communicate with family members. And I think that's kind of the place that I really took off. And that's why this has a very special place to me, and why I'm excited to be back here working with all you guys because of my experience over the 5 years there. So I ended up then doing my hand fellowship. I chose hand because it was the most diverse of the different subspecialties. And also I had great mentors. Joe Letty, who was the chairman at the time, was a hand surgeon. Mike Coyle, now since retired, and Dave Kirschenbaum, who some of you guys know. All three of those guys were close mentors. They were friends of mine, encouraged me to do it, and ended up getting a position down at Duke. And Duke is one of the kind of the ultimate, academic institutions, from everything from undergrad to the medical school to the orthopedic department. And it's a storied tradition. The chairman of the orthopedic department was a hand surgeon, and he was my mentor when I was there. So my fellowship was comprised of microvascular surgery, plastic surgery, and orthopedic surgery. So I got a lot of great training that a lot of people don't have. So 4 months was spent with Scott Levin, who's now the chairman at Penn, doing plastics work. 4 months with Dr. Urbanek, who pioneered the free fibular procedure. So I did a lot of microvascular. Plus, we were the replant center for the whole southeastern portion of the United States. So people would come in with these crazy injuries, and we would try to put them back together. So I was hooked. I mean, I loved being a senior resident. I loved my time at Duke, and I was convinced that I wanted to stay in the academic arena. I was curious. I was interested in what people had to say. I started to do a little research when I was down there in Durham, and I thought that was the trajectory for my path forward. Even so much as me going to UNC, and they had me come down and they offered me a faculty position. And I was about to take that position when we had our first child just before we left for North Carolina. And my wife said in March of that year, I really want to come home to New Jersey. And that's where her family was. So I did an about face, and I kind of looked around and saw what was in New Jersey. and there wasn't an academic position. So I ended up joining Brielle Orthopaedics. One of my good friends from residency was there, and it was just a great opportunity because they needed a hand surgeon. The current hand surgeon had already announced that he was going to be leaving in about a year and a half, and it was a young group. The area needed orthopedic surgeons, and I practiced down in the Point Pleasant, Brick, Manasquan area. So we ended up coming back to New Jersey, and I thought, you know what, I can still do some academic stuff. I'm going to do some outcomes on my patients, and I'm going to kind of have this, you know, academic flair to a private practice. And, you know, it's very, I will say that it is very, very difficult to do. And, you know, I didn't have the support system. I didn't have the support of my partners to do academic work. You know, even just collecting outcomes, I had this big file cabinet in my office where I would have paper outcomes. And, you know, as my practice started getting busier, I said, you know, how am I even going to take all these paper outcomes and put them into something or into a database? And, you know, lo and behold, pretty quickly, that idea of the academic stuff kind of fell by the wayside. So my only job has been with Brielle Orthopaedics. This is where I started, and this is where I still am. And I came in 2005, and I've been, and that was through 2018. I was the managing partner, officially called the president, for 2011 to 2013. The way they had structured it was everybody rotated for about 2 years. And they asked me to stay on and do a third year. So I did 2011 to 2013. And then just recently, this past fall, I was asked to come back on as we were having a couple little hiccups and we were planning to do a merger. So in terms of my administrative role, the last 6 months has been nonstop to get us, you know, back on solid footing and to do this merger. When I took a break from the managing partner, then I took over a hospital position where I became the chairman at our hospital, main hospital, which is now Ocean University Medical Center, since we have internal medicine, psychiatry, and family medicine residents here. So, and we do the teaching for the family medicine residents for their orthopedic rotation. So I spent 2 years doing that, building up that department. And then honestly, for about, this was in 2018, but in 2015, believe it or not, we started talking with Rothman, and they were growing. Now, Rothman Orthopedics is a really fantastic place. They have about 200 orthopedic surgeons, and they are the primary faculty for Jefferson. They also have a little bit of relationship with a couple of the places up in New York City at NYU, and then at the Hackensack. I think a couple of the guys are at Temple. They do PCOM, Philadelphia College of Osteopathic Medicine, and the Rowan program as well. So their guys are spread out and they're doing academics in a lot of places. But the interesting thing about Rothman is they are a private practice. They are completely, and when I say private practice, they are completely owned by physicians. So they are kind of a private practice that is very, very focused on academics. And one of the guys who's a good friend of mine, Ossiphilius, said, you know, we're 100% private practice, we're 100% academic. And I think that that's very true. So we spent time with them from 2018 to 2021. And we had an interesting arrangement where we basically said we want to date for a few years and see if this is what we like before we completely integrate. And what happened was we decided at the very end that this was not the right place for Brielle Orthopaedics, and we ended up going our separate way. So in April of 2021, we became Brielle Orthopaedics as well. And I got very interested in the academic work, and we can talk more about that. But then I called Charlie Katt and I asked if I could come up and do some work with the Rutgers program. And he was very gracious to allow me to come up. And one of the nice things, because of COVID, was they were doing a lot of the conferences remotely. So I could be down at the shore and still be a participant in a lot of the educational offerings. So I've been at Rutgers Robert Wood for just about 1 year now. We're coming up on a 1-year anniversary. The merger we did was we merged with another group close to us, which is Orthopaedic Institute. And this went live January 1st. This is what I've been working on from October or September of 2021 until we went live, and I'm still working on it. We're now Orthopaedic Institute Brielle Orthopedics, and we're a division of Ortho NJ. So when we came in April, we joined Ortho NJ, which is the super group. They call it the super group in New Jersey. We're the largest orthopedic group with 125 doctors and 25 offices. So our practice now is 34 physicians, 9 offices, 2 additional physicians have signed and 4 are likely to sign. And I'm the co-president, along with someone from Orthopaedic Institute, of the organization. And at last check, we had 273 employees currently working in the group. And where we're headed, this is our new logo of Ortho NJ, 120 physicians, 25 offices, and the ones you guys know are the University Orthopedic Associates. They're most of the teaching faculty here at Robert Wood, and they're going to be part of this, as well as Princeton Orthopedics and a few other groups. So, you know, in the next couple of years, there'll be hopefully more integration, more work, more collaboration between these big, powerful groups. So, you know, like I said earlier, it's all gray. So what do people join when they come out of their residency or their fellowship? In the past, most orthopedic surgeons joined a private practice, right? And what does a private practice mean? It means physicians own the business, okay? So when it comes right down to it, on the forms, you know, it's owned by physicians and their shareholders. And if you're a new physician and you're going to be offered to be a shareholder, you're going to buy into the business. And then you have a percentage equity. In a lot of these practices, it's an equal equity as the other partners. How do physicians in private practice get paid? It's mostly fee for service. So if you came in and you had a pain in your wrist and you saw me, there would be some sort of a negotiated rate between our practice and your insurance company, let's say Blue Cross. And, you know, let's say that rate is $100. You might have a $50 copay that you paid to the receptionist when you came in. And then the other $50 would be collected by us sending an electronic bill to Horizon Blue Cross. And if everything goes well and it's a clean claim, in 2 to 3 weeks, they would deposit the other $50 in our account. So we have to do our own contracting. Very, very rarely are people what we call self-pay. So do people not have insurance and they come in and they say, I want to see a doctor for whatever reason. And we say, this is our rate, and they pay cash. That is extremely rare. That's actually less than 1% of our revenue is from self-pay. So most of our compensation comes from these contracted rates with the different insurance companies, and everyone's different. So you have to do this with Blue Cross, you have to do this with Cigna, you have to do it with Aetna. And the big one is the government programs, which are Medicare and Medicaid, Medicare being a federal program, and those rates are already determined, and then Medicaid, which is a state program. So that's a lot of work. And that's one of the benefits of the bigger group that we're in, is we can do all that contracting at a higher level. So instead of, you know, having 6 different administrators with physician support figure this out, we can just do it at one level. And size does matter, because, you know, the insurance companies would love to speak to, you know, one person for all these physicians than having to have 6 separate conversations. So it does make a difference, you know, how large your group is. So that's why the idea of coming out and just hanging a shingle and being a single guy is really, really rare these days, because it's just tough to do. And the insurance company says, I'm going to give you a rack rate, and that is not very good. But if you come in as some sort of a group, they'll, for whatever reason, pay you more money. It has nothing to do with the quality of your care. It honestly has to do with the size of your group. Now, that being said, there are also some different payment models. They're kind of a minority of the way we do things. And they've just started over the last few years in terms of like bundled payments, where they give you X amount of money for a total hip procedure. And if the patient leaves the hospital quickly and doesn't do a lot of rehab and doesn't use a lot of lab testing, let's say, there is some savings there, and then the physician gets a portion of that. But those models are very in their infancy, and that's also a very small percentage of our revenue. So in private practice, your compensation comes from the work you do, and it comes from your clinical productivity. Okay, so you see more patients, you do more surgery, you spend more time in the ER, you make more money. Private practice also allows you, for the most part, more flexibility, and I put in parentheses, less bureaucracy, because you own the practice. And if you have partners that are reasonable, and that's another big part of this, is finding guys and females that you can work with and share a similar value system as you, and kind of want to have time for their family as well, you can do certain things. So if my daughter had a school play in the morning and I wanted to start my hours at 9:30, well, usually I'm able to do that. I would tell my clinical coordinator or my medical assistant, hey, look, I'm going to be a little late, and I'm allowed to do that kind of thing. So when you own the practice, you have a lot more kind of freedom in terms of how you do things. So the next step from that is academics. And academics, when I think of academics, there's the kind of the traditional academics, and then I'm going to tell you about kind of the gray system in there. And like for academics, I would talk about employed academics. So a place like Duke. So when you're there, the faculty was employed by either the hospital system or the university, depending on how things are structured. And then you're compensated on a mix of different things. So you may get you might just get a salary, and that may be based on your rank as an assistant professor, associate professor. It may be based on your clinical productivity. It may also be based on some of your scholarship. If you're writing a lot, or you have a research funding, maybe you get a portion of that. So it's a little bit of a mix, and it doesn't always tie together in terms of, correlating the work you're doing clinically with the compensation you're getting. Maybe the chairman's getting, twice as much as, the associate professors. So in academics, you're an employee of the educational institution or a hospital system. A lot of times the relative value units are a way you would get paid. And the relative value units is a way of equating a carpal tunnel to a total hip to a washout of an infected knee. And it doesn't matter who the payer is. I mean, typically, the commercial pays a little bit better than the government plan. And in this case, it doesn't matter. You could be seeing all patients that don't have insurance, but as long as you're generating, relative value units, you're going to get compensated based on those. Whereas, in private practice, if you're seeing a lot of people that don't have insurance or people that are underinsured, that's going to go right to your bottom line. A lot of that goes away at the academic centers. The base salary and then the incentive bonus that we talked about. And a lot of these places have a scholarship requirement. A tenure track, I mean, you hear of that existing kind of in some of the undergraduate departments, but there are certainly clinical departments that have a tenure track position where you have to secure a certain amount of research funding by a certain amount of time. And then you develop tenure and you have a little more security. So someone who's a physician scientist, which are not too common in orthopedics, but they're out there. And I'm talking about people that have an MD, PhD. There are also physician scientists that are just an MD, but have a very strong interest in research. They may end up at an academic institution. And a big thing may be just in terms of the lab equipment. So you may not be able to have some of these lab equipments, these big capital purchases, if you're in private practice. Like the private practice could never afford to do that. But through the grants and through the educational institution, some of these things become available to you. So if you want to do more, I think I would say basic science, translational science, you may want to find yourself in an academic institution. And then there's also going to be an expectation to generate some grant funding. And the third one here is employed by a health system. So more and more people are coming out now and they're just joining a health system. It might not be an academic institution, but it might be, for example, Hackensack Meridian Health. I mean, Hackensack Meridian Health does have the medical school, but let's say you're Hackensack Meridian Health at a community hospital. You might be hired by them for a base salary with a potential incentive bonus, and you're just employed. You have a contract that says, I'm going to work X amount of days, or I'm going to have to do this or that. And you don't become partner, you don't own the practice, but it's a good job, you get paid well, and you get some security in terms of patient referrals. So then there's this next one, which is this privademics. And I mentioned that briefly about Rothman. And I think that the top three up here, Rothman, the Hospital of Special Surgery, which I'm sure you guys have heard of in New York City. And then the other one, Rush, which is in Chicago. These are three of the kind of ultimate privademic institutions that in a lot of ways kind of have the best of both worlds, where they have the private side, so they're owners of their company, and then they're still very involved in the academics, whether it be the teaching, whether it be the clinical research, or even some basic science and translational research, depending on where they are and what their interests are. As I mentioned, some of the guys at Rothman said 100% private practice and 100% academic. Good and bad with that. If you like both things, it's a great place to be, but it also means that you work really, really hard, because you can't slack on the private practice because that's where your income is. And then, on the academic side, you have to find time to make it happen. So at Rothman, a portion of the compensation was based on scholarship production. So when you incentivize something and financially incentivize it, you get more of it. So basically, it's hard. It's not impossible, but because you have grant funding, but it's hard to monetize scholarship. So if you're having a medical student shadow you in the office, you're not getting paid for that. If you have a resident who is assisting with your cases and you're teaching them surgery, you're not getting paid for that. So you're preparing a lecture on scaphoid fractures and it takes you 5 hours on a Sunday, you're not getting paid for it. So all of those things, you're doing, and that's taking time out of your week, and you're not generating revenue from it. So in that privademic model that incentivizes scholarship, there's almost a redistribution of a fee for service income. So you have so much coming in from your clinical work, and then it kind of, that bucket gets kind of redistributed to people who are participating in scholarship. And then you have to look at that and you have to say, is this something that I can maintain? Is this something that, I want to be part of my practice? A lot of times these places are very well known, they're renowned, they have, some of the top scholars, people that are talking at a lot of meetings, and potentially they can generate higher contracted rates with some of the insurance companies. Another thing is that you're with like-minded colleagues. So these are people who, want academics to be a part of their career. They're curious, they're interested in why things happen. They're kind of on the cutting edge of where the field is. And, when I'm going to say intense here, I mean, I think that is true, and it has to be true because there's no way you can do everything and everything well, but you try your best. And a lot of these guys in these places are very driven. And then there's also privademics. And again, an example of this would be University Orthopaedics, where the scholarship is not monetized, right? These guys are the teaching faculty for the residents. They help you guys out with the clerkships and things. But as far as I know, they're not getting additional money for their scholarship. So they're doing it all because they enjoy it and they want to be part of it. But it's not something that's monetized, and that's just a different, way of doing things, and pluses and minuses to it. So you can have privademics. If your practice, let's say, is involved with a residency program or medical students, and it can either be monetized or not, and they're both privademics. And if you ask me, like today, where do I find myself? I mean, I think I fit in this privademic role because I do still spend a lot of time with the conferences with the residents. I'm interested in helping with the students, but I'm not, formally a employee of a university. And then I'm on this bottom side right here, where the scholarship work I do is not monetized. So what's my typical work week? And don't use what I do as a basis for what's life as an orthopedic surgeon or a hand surgeon, because I do wear a lot of hats. But I guess I do have a little bit of that surgeon mentality, and I wake up very early in the morning. So I usually get up between 5 or 5:30. But if I have important stuff to do, I'll sometimes get up earlier, in the 4s, just to get some work done before the clinical day starts. So I'm usually in my office by 7, or I'm at the OR by 6:45. Different places have different start times, but I operate in ambulatory surgery center. And at both places, I have a 7 a.m. start time. So I'm usually there at least 15 minutes before. My typical day, I work somewhere between 5 or 6 at night. In terms of call, right now I take call every 6th night, and that's general orthopedic call. And we stack our weekends. So when you're on for a weekend, you're on Friday, Saturday, and Sunday. And then the other weekends you're off, so you have time with your family or personal time. We cover 2 hospitals right now, Ocean Medical Center in Brick and Centra State in Freehold. And the other thing is that there's only one other doctor in my group that does hand surgery. So a lot of times, and hand does have a lot of injuries and acute events, a lot of things through the ER. So I might not even be on call, but I get a call from one of my partners that, this or that is in the hospital and they want our group. And I find myself in, more often than every 6th night taking care of things. So it is a lot of back and forth to the hospital. It's a lot of, I can't make this or I can't make that. And I think that's where that's where you need to have a good support system. I mean, my wife is a saint about it, but it is, not the easiest when, your family's planning on you for something, and then you have an acute emergency in the ER and you're running back to do it. So if you want something that's 9 to 5 or 9 to 3, and you want to be good at what you do, I don't think you should consider hand surgery. There's probably some other things in orthopedic surgery that, might be a little less emergency intense, but hand surgery is probably the most. They did a study and said what subspecialty spends the most amount of time after hours in the operating room, and hand surgery was first. And believe it or not, pediatric orthopedic surgery was second, followed by trauma surgery. And then I do emails, my reading, my scholarship in the evening. And then right now I work several hours on the weekend, usually first thing in the morning before my kids are up and running around. But I try to find some extra time to get in the other stuff that's important to me in my professional career. So I'm in the office Monday, Wednesday, and Thursday, and I do surgery Tuesday and Friday. So, my schedule is very different than a resident, because a resident might do a half day at clinic and then spend 4 days in the operating room. And I'm a busy surgeon, but I only spend 2 days in the operating room. So 60% of my time I spend in my office seeing patients, and about 40% of the time I spend operating, and that includes the call cases as well. So I see somewhere between 35 and 45 patients per day. That's 5 to 6 patients per hour. So, I see patient, and it sounds crazy when you break it down, but every 10 to 12 minutes, I'm seeing another patient. And that means understanding why they're coming, reviewing their records, diagnosing them, speaking to them about their condition, and then dictating somewhat of a concise summary of why they were here. I have a physician assistant who works with me 4 days a week. And when she's with me in the office, she might see an additional 20 people. So it is busy. I mean, it is nonstop from, we start patients at 8 o'clock, and I'm very adamant that my first patient is walking in the room at 8 o'clock. We start right on time, and it is full steam until 5 o'clock. It's a full day. And some of that is my choosing. If you say, hey, look, I want to see 4 patients an hour and I want to end at 3:30, you can do that. I love it. I can't get enough of it. As soon as I leave the one room, it's almost like, I have to stop and dictate. And sometimes I dictate at night because I can't wait and see what's, hiding behind door number 2. I mean, I'm just so flattered that, people chose to come see me for their problem. And I just can't wait to get into that next room and see if I can help them out. So even though I'm a surgeon, I do a lot of work in the office. It's diagnosing, it's counseling, it's reassuring, it's cortisone injections, it's ordering physical therapy, it's, signing people up for surgery, it's putting a cast on, it's taking a cast off, it's taking sutures out. It's all those things that go with a typical office day. And then in terms of staff, I have a front desk clerk, I have 2 medical assistants with me, I have a surgery scheduler that's shared, and the physician assistant 4 days a week. And their livelihood is based on, me coming into the office every day and people deciding to come see me. So this is, I mean, when you talk about responsibility, you talk about a responsibility to your patients, but you also talk about a responsibility to your employees. And, they give me 100%, and I try to do the same for them. And this is not to count the countless other people between billing and scheduling and durable medical equipment and everything in between. Like I said, we have 273 people that currently work at our company. Surgery, Tuesday and Friday, I operate at 2 separate surgery centers, and I do between 600 and 700 cases per year. I do 6 to 7 operative cases per day. Some of these cases are very small, like a carpal tunnel or trigger finger. And then other times I'll have a major case that'll take me 3 or 4 or 5 hours. So I wanted to just kind of give you an example of, why I like hand surgery, why I chose it. And I said it's the most diverse of all the orthopedic subspecialties. And I tell people because I can be a dermatologist, I can be a plastic surgeon, I can be a neurosurgeon, I can be a vascular surgeon, I can be an orthopedic surgeon, all at the same time. And we treat, because everything in the hand encompasses all of those different subspecialties. So this is just an example of somebody that we got called to see emergently. And this is someone with a bad infection in their hand. And the treatment for this is to open it up and drain the infection and prevent damage to the underlying tissue. So this is a relative emergency. It doesn't have to be done, right now, but it should be done in the next couple hours, and to evacuate the infection. This is a tumor, so I get to be, a oncologic surgeon as well. This is a benign tumor. It's called an enchondroma, but this person was doing jiu-jitsu and went to do a block and had pain in the level of their hand. You can't see it here, but there's a little crack on the cortex there. And this was just diagnosed incidentally. So he needed to go to the operating room and have what we call a curettage, or excision of that lesion, filled in with bone graft and protection, and to have that heal.
I'm sorry, Dr. Katt, on that last one, could you kind of point out where that tumor is?
Sure. So proximal phalanx, middle phalanx, distal phalanx. Look at the middle phalanx. Look how ballooned out this is right here. Okay. So instead of it being this kind of, thickened cortex of white, it's this whole area right there is the abnormal lesion.
Thank you.
So this is something else I do. And it's interesting when they say hand surgery, it's really hand and upper extremity surgery. So I go up and, again, I take general orthopedic calls. So I take care of broken hips and broken ankles. But mostly what I do is the upper extremities, so clavicle fractures. This is a patient that had a proximal humerus fracture that was not reconstructible, that we ended up doing an arthroplasty procedure on, and this is what's called a reverse shoulder replacement. So this is something that would be a little bit longer. This would be about a 3-hour procedure, and we go in and we basically create a new shoulder for this patient. This is, kind of bread and butter orthopedics. This is a patient that had a fracture of the radial head, and it was, again, not fixable. So if it's in more than 3 pieces, the pieces come out, and a prosthesis. This is metal. Okay, so you can see it's very dense. This is a radial head implant. And then the patient also had a fracture of the proximal ulna, which was fixed with a plate and screws. This is something we don't do so often, but for the engineers out there, you get to kind of tinker with this kind of thing. And this is called an external fixator. So an internal fixation is below the skin. External fixation is outside the skin. So there are certain circumstances where you can't put, the bone is too smashed, where you can't put fixation in it, and you just basically want to span a joint, which means you put fixation on one side of the joint and on the other. So you're spanning the wrist, and then you're using these metal bars to kind of hold the structure of what's below it. So we use these sometimes in trauma settings or when things are not reconstructible. But this is an interesting case. We do this under X-ray, and this is an application of an external fixator. We do get complications. So this is an internal fixation. So it's below the skin. And this is a patient that had a fracture of their wrist, and we used a plate and screws to hold things in position, but he broke. The screws stayed with this fragment of bone, and the plate stayed right there. So this is a guy that needs to have an operation to have this plate come off. And then we ended up putting an internal fixator, which is this, but we did it as a spanning fixator placed on the top side or the dorsal side of the bone. Here's just another example of another internal fixation of the elbow, where we're using very small screws and plates. And sometimes, and what I like about this too, is sometimes you have, the guideposts of what to do, but when you're in there, not every fracture is the same. The fracture fragments are different, and you have to be intuitive and kind of use the instruments you have to find something that's going to make the elbow work and the elbow stable. And this is, I used a plate in a non-traditional place in order to stabilize this fracture fragment and get the joint reduced. So when I talk about plastic surgery, this is clearly in the plastic surgery side. And with hand surgery, 60% of hand surgeons are orthopedic surgeons, 30% are plastic surgeons, and 10% are general surgeons. And you can do anything within the hand. It's a lot of times the plastics guys will do more of the soft tissue, and the orthopedic hand surgeons will do more bone. But it doesn't have to be. It's kind of what you're comfortable with. And I had a lot of experience on the plastic side when I was in fellowship, and I like doing things like this. So this is a patient who had a degloving injury on the volar side of his thumb. And what we did here is we took what's called a kite flap. So we lifted up this piece of skin, we took it all the way back, we found the artery, and then we tunneled it underneath to restore skin and subcutaneous tissue on the volar side of the thumb. And the reason we can't just put a skin graft on there is the skin graft won't adhere to bone, it won't adhere to exposed tendon. You need some subcutaneous tissue as well. So this is a kite flap that we brought around, and then we backfilled this with skin grafting. So in it, and this is not something I'll do every day, but you can see that, I could have an ORIF of an elbow, followed by something like this, followed by an excision of a tumor, followed by, removal of a mucus cyst. This is, one of the surgical emergencies you guys will learn about, which is compartment syndrome. And this person had an intense pressure below the level of the fascia. Surgical emergency. This is when you get called in the middle of the night. It's always at an inopportune time. And then you go in and do a large fasciotomy and open up and decompress that volar compartment and take the pressure off those muscles before they become necrotic. And then this is when I talked about dermatology, I see things like this as well. And if you guys are wondering what that is, that's an aggressive skin cancer. That's an aggressive squamous cell carcinoma. So that's one where we take the patient to the operating room and we need to do a resection of the lesion and then fill in with some skin grafting after we wait for margins. And again, this is some of my plastics work here. This is probably more plastics than anything, but sometimes my colleagues will consult me to do more complicated things. And this is just a woman that, for whatever reason, no one wanted to take care of, but an abnormally large lady who was obese that had a horrible injury where she lost all the skin on the anterior surface of her leg. And this is a split thickness skin graft. And in order to get more, because you can only take so much tissue, we did a mesh. And so we increased the size of that piece of skin so it covered a much larger area. So this is a mesh skin graft that went on to successfully take and re-epithelialize her leg. And then just to, another one, this is a person that was sent to me that couldn't move her finger. She underwent a repair of a flexor tendon and never regained any motion despite numerous attempts at physical therapy. And she scarred her flexor tendon into the level of the hand. So in that case, you can't just substitute a new flexor tendon because it will scar back in. So we ended up doing a two-stage procedure where we prepared the bed on the right side here, and that's a silicone rod. And then we come back at 3 months and we use the flexor tendon. We actually tied these two flexor tendons together, and then we'll make an incision in the level of the wrist and flip one of the tendons out and use that for our length and to reconstruct her finger flexor tendon. So this is kind of, working in a different skill set where you have to think about, balance and appropriate soft tissue coverage and getting everything right for a two-stage procedure. So I'm kind of all over the place. I'm kind of all over the place in terms of, the different surgeries.
They were doing a reconstruction of a flexor tendon.
Is that a lecture?
No, it's a talk.
If you're not asking a question, could you please mute yourself?
No, it's a...
All right, let's come up for air here. And why don't we stop at this point and let me take some questions.
Well, thank you. I just want to start by saying thank you, Dr. Katt. This has been extremely informative.
We got a long way to go, Ali. So
great. I'm here for it. Actually, does anyone have any questions? I'm going to open it to the floor before I ask mine.
I have a question. So I came in late. I'm not sure if you have covered this. So since the Obamacare, physician-owned hospital is basically banned. So we're seeing like consolidation of a lot of healthcare system, and you can see that in orthopedic, or you can see it on those hospital level, and slowly we're seeing it on the clinical level as well. Do you see any of that happening around you? Does it affect your if so, does it affect your conversation? Do you see how we're trending when we become orthopedic surgeon one day? So do you have any thought on that?
I think you broke up in the very beginning. Can you just say that again? I'm sorry.
Oh, I'm so sorry. Can you hear me now?
Yeah.
Yeah, so for the Affordable Care Act, they banned the physician-owned hospital, and we have seen a lot of PE consolidation on the healthcare like network, pretty much. And then it slowly is creeping down to the clinic side. I mean, from the dermatology, from the ophthalmology. Now we're slowly seeing orthopedic sides because they're consolidating. They have more leverage to negotiate and all that.
Yeah.
So obviously, so I just want to see, do you see that within your clinic, like around your peer? And if so, how is this going to affect us when we decade later to come up? I'm not sure if it's happening with other people. That's why I'm asking.
All right.
Yeah.
So the question is the moratorium on physician-owned hospitals, first you wanted to know about, like, how does that affect my practice? And then
Yes.
Also when you said PE, you're talking about private equity coming in and kind of buying up these groups.
Yes, and then like for us, maybe one day we'll have to work with PE because we don't have the leverage like the PE to negotiate the insurance and all that.
I mean, we're jumping ahead a little bit because I have something on it, but I will talk about it because I think that's very, very important. And when I started out talking and saying, like our group now is going to be, I mean, our actual company is 120 doctors. I mean, if you look, we are all under the same tax ID. What does that mean? I mean, one thing I really liked is that, I only had a few partners. And like I said, if I want to take this day off or I want to do that, I have all that flexibility and I'm my own boss. But when you join a company of 300 or 400 people, you kind of lose a little bit of that autonomy. And for that company to be successful, it has to have some structure and you have to fall into it. Big is going to get bigger. And I think that the private equity is very interesting. It's just starting in orthopedics. So, I mean, I can count the few practices right now that have private equity backing, but it's definitely out there. I mean, I can tell you that I already had a private equity group come to us, and they came in with a lot of money and they said, we want to buy you. And some of my partners said, oh my God, and this is great. And we took a step back and looked at it, and it certainly wasn't the right option right now. But I think you're going to see more of that. And when you have private equity, the people typically who do the best are the old guys because they get the money and then they're leaving in a few years and they kind of sell their young. So that is something to keep an eye on, but I don't think it will be commonplace when you're coming out. By the time you're done with your career, maybe, but I wouldn't worry too much about it. I think those deals will still be there if you want them.
Thank you so much.
You're welcome.
I appreciate it.
Any other questions?
Yeah, I had a quick question, Dr. Katt. In terms of like some of the privademics, practices that you were discussing, like Rush, I believe it was like HSS, and then Rothman. I guess in all of those positions, would a physician have to have some type of like professor role since it's like 100% private, 100% academic? Because I know like at Rothman, some of the faculty there, or some of the positions there was like faculty at like say Jefferson and like Sidney Kimmel. So I was just kind of wondering like the interplay there. Is that it always something where if you want to be in the academic role, you would have to then take part, maybe say teaching, or you could maybe just do like research per se?
Yeah, so that's a great question. And I think that, so like at Robert Wood, when I came, I think it was like I would participate in, and I think the number, don't quote me on it, but I think it was like 30 hours of lectures per year. And by going to grand rounds or going to fracture conference, that counted for an hour and a half. So, I mean, do the math. It wasn't a lot of commitment that I would have to make. I didn't have to write any papers. I didn't have to do, any specific teaching than that. That was kind of the minimum thing. And then, I have a title of, clinical X of orthopedic surgery. So I think those titles are, at least at the clinical level, are given out pretty liberally. But it all comes down to that payment structure. So like if you say, hey, look, I want to go to Rothman, but I don't want to do any research. Well, it's not going to work because a lot of your compensation is going to be based on, did you participate in scholarship? So typically guys that don't want to do it would say, this is crazy because I'll keep more of what I make if I just go into private practice.
Okay, thank you. That makes a lot of sense. I appreciate that. And just another quick follow-up question about this procedure that you have on the screen right now. I just wanted to know, like, if you could, I guess, go through it again, because I just wanted to understand, like, when you're tying the other tendon, I guess, like you said, are you going like through the carpal tunnel? Would you like have to
So
retinaculum or?
Yeah, exactly. So we have two tendons right here. We have a superficialis and a profundus tendon. We just took out all the scarred stuff right here. Okay. And then I joined these two tendons together. So I made basically a loop. So if you think you got a tendon coming up, you got the two tendons coming up here and now looped, and this is going to be kind of the halfway point. So if I cut one tendon like this, and I just flip that tendon forward because it's not attached anymore, kind of pull it right out through the carpal tunnel, then I have that additional length that I can bring to the tip of the finger. So the old way we would do this, if we didn't sew them together, is we would take an extra tendon, typically a palmaris longus, which you really don't need, and 85% of people have. You would take that tendon out, and then you would sew it in here, and then you would sew it in here. And there are a couple of things with it. One, it's extrasynovial, so it's not the exact same kind of constitution as this. But then also, when you join something together, we call that an anastomosis. So in my case, I've already done one anastomosis, and there's no tension on it because it's just sitting here, right? So then when I do my final procedure, I only need to worry about one fixation point. Whereas if I took a free graft, then I have two potential sites of problems because I have to do an anastomosis here, and then I have to fix it there. So there's double a chance to have a problem.
Okay, thank you. That makes sense. Yeah, I was wondering, like, with the flexor retinaculum around that carpal tunnel, like if it made it a little tight to kind of get through.
It does, and that's why we try to stay away from this. So we'll make our cut over here, and we'll kind of just play with the tendons, find out which one it is, cut it, and then pull it out. So we don't even have to go in this whole area right there.
Okay, yeah. And then thanks for pointing that out, because I can clearly see now, like, where profundus is, and then also superficialis, since like the superficialis will kind of cut down a little shorter and the profundus will kind of continue through. So that makes a lot of sense. So
that's exactly right. Yep. All right, you want to keep going?
Yep.
All right. I'm going to close this up. All right, so now we're going to get into some nitty gritty, and this is kind of the fun part. And so for me, it's all about taking good care of patients. I mean, that is what drives me, and all this other stuff comes because we take good care of patients. And never forget that when you start putting this financial stuff in front of taking good care of patients, then you start to get into problems. But in private practice, in our private practice, I want to explain to you guys how we get paid. All right. And this is probably something that, I didn't learn until I was actually in practice and was going to become a partner. So you're going to hear this, 10 years earlier. You keep this filtered away when you think about jobs. So when you first come out of training, you're going to get an employment contract. And that employment contract is going to give you a base salary. And most often it's going to give you a productivity bonus. So it's going to say, if your receipts are above a certain amount, I'm going to give you a percentage of those. Okay, I'm going to give you a base salary so you can pay your mortgage or you can pay your rent payment, you know, your car and, you know, the other things for your family. And then if you're busy and you start to generate referrals and business, we're going to pay you a percentage of it. After a period of time, if the relationship is working out, they'll ask you, hopefully, to become a partner. And when we talk about being a partner, you're going to become an owner of the company. There might be a buy-in. They might value the company at X. And if you're one of 10 partners, you're going to pay 10% of that, and then you will become an equal partner. And again, all those things can be discussed in more detail, and you kind of have to look at the contract and make sure that everything's fair. But once you're a partner in our practice, and this is what's nice about orthopedics, is we have a whole lot of other streams of revenue, okay? So what we do is we have the partners here, and I just kind of blanked everything out. And some of the doctors in our group are partners and some are not. Some just don't want to be as busy. Others, you know, don't want to take call. Other ones aren't surgeons. So there's a variety of kind of criteria you have to meet to become a partner. So for the partners, we look at this and we look at, this is your non-ancillary gross income. This is all your physician receipts. So if your surgery and your clinic time, your stuff you do in the ER, this becomes your non-ancillary gross. Then you're going to get to your overhead responsibility. That's your employees, that's your billing, that's your rent on your building, that's your malpractice and everything like that. And when you deduct your overhead from your non-ancillary gross, you get your profit. Then and these numbers have changed over time, but the way we are right now, we are a 75-25. So 25% of the money is split equally. Whether you're the highest earner or the lowest earner, everybody gets 25% of that pool gets split equally. And the reason we do that is because we don't want to be competing with each other, right? We want to work as a team. And we don't want the guy that does knees to try to do a carpal tunnel or take a case from, you know, this or that. And we don't want any of that. So by splitting some of the money, we kind of equalize that. And we also say, hey, look, you know, that spine patient that you operated on, well, that's because, you know, Dr. Katt took care of, you know, his daughter's wrist fracture. So it all kind of comes around and makes us look to the whole of the practice and to grow it. And the other 75% is based on your productivity. So if one guy wants to work all the time and another guy doesn't want to work a lot, maybe he wants to work 4 days a week and he wants to take a lot of vacation. And when he's here, he wants to get out at 3:30. Well, he's not going to make as much. So we go equal distribution, like I said, 25, split distribution, that's the 75. For some reason, if someone's really low, if they don't cover their overhead, which does happen if people take a lot of time off or they're just not as clinically productive, they have to pay that back. That's not free. And then call. So we get paid. I told you we take call at 2 hospitals. One hospital, we get paid to take call. So that was negotiated a while ago. And the other hospital, we don't get paid to take call. So all that call money gets down here, and let's say I take 3 nights, I'm going to get that call money and my partners will get the same thing. We own physical therapy. We have 6 physical therapists that are employed by us, and a lot of our patients need physical therapy. So they go downstairs to physical therapy. They don't all come to our facility, but we have a great physical therapy department. We talk to them constantly. We're constantly figuring out plans and you know, best treatment, and we work really well with them. And if physical therapy works out and it's profitable, we all split the profit of physical therapy. So if one guy sends everyone to physical therapy, another guy doesn't send anybody to physical therapy, we still split it equally. So all of these, and that's our practice, all of our ancillaries, we split equally. If you're a partner, you get an equal share. Injections. So when you talk about injections, we're talking about something called viscosupplementation. This is your Orthovisc, your Synvisc, things like that. We buy the medication from the distributor, right? And then we inject it give it to the patient as an injection, and then we bill the insurance company. There is a spread on that amount, on that process. So in addition to getting compensated for actually giving the injection, we get a spread on the medication itself. So that's profitable, and that goes here. Durable medical equipment, if somebody gets a wrist brace, that gets bought by us. You know, it's a whole separate category, and it's a business, and we run it like a business. And the patient needs a wrist brace for their injury. We fit them with their wrist brace, and then we bill that to the insurance company, and they pay us. Most of the time that's profitable overall, and that gets written here in DME. And then X-ray. So we take a lot of X-rays in the office. And if the costs of the running X-ray, whether it be maintenance on the machine, I mean, now everything's digital, so we don't have to pay for film. And then the X-ray techs that we employ, often X-ray is profitable. So that's another one here. And now we have columns 1 through 6. These are all of our employed physicians. So it's either someone starting out, it's someone that's, you know, at the end of their career, it's non-surgeons, depending on what you have. All of these people who are getting a base salary and bonus, they should be productive, and they should be contributing to your bottom line. And, you know, if they're not, and they're not for too long, then they're probably not going to be part of your practice. So very quickly you can see, you know, hey, look, I'm working, I'm seeing patients, I'm doing this. That's only one portion of all these ways that I'm generating income. And that I think is the power of the private practice, because a lot of times in an academic center or in a employed model through a hospital system, you don't see any of this stuff right here. All you're going to see is a salary and then a productivity bonus. Just to finish out the formula, we have physician assistants, and the physician assistants bill. Most of the time they're profitable. The PAs, like I mentioned earlier, I have a PA who's with me 4 days a week. She's helping me with surgery. She's seeing patients in the clinic. She's doing emergency work. That typically is profitable. Our clinical assistants, I have a absolutely phenomenal clinical assistant. This is a negative, but in our model, you know, you're responsible for your own clinical assistant. Some guys have nurses, some have very experienced medical assistants. You have the leeway to decide the compensation you want to pay them, and that goes right on your ledger. Staff bonuses, if that happens, that gets written here. Management, and currently I'm doing the management, so I get a little bit extra. The pension, you want to always pull out the maximum in your pension. Another benefit of the private practice, you can figure out how much you want to do and how to structure things to make that work. And then you end up with your net income that says Q2 net income. And we do this every quarter and figure that out, and then bonus out the money. So this is just the private practice, and you can see all the different columns and all the different things that are happening kind of behind the scenes. I mean, most of the doctors that aren't involved with the management, they don't even really see this. They just see this spreadsheet at the end of the quarter and then see how they did. I just took this right off the web. How much did orthopedists earn? And you can see that according to this statistics, we are the second highest paid subspecialty of medicine behind plastic surgery. And then this other one showed the median being at just over $500,000, and then, you know, the 90th percentile out here at 800. And I can tell you for the last 10 years, I'm living over in this area right here. So if you do things right, if you work all of these angles, you know, there is a potential to just generate an enormous sum of money. So like I said, it's not about this, but good partners, good care of patients, handling each one of these issues that you can be very rewarding financially. So when we talk about income sources, and this is the kind of the finance portion of the talk, it's, in my mind, it's equity, 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 and that is ownership of any asset. And the more ownership of things you can have, the more income most likely is going to come from that. So I think, and it's so important when you're financially savvy, is to look at obtaining equity. And passive income, that's another thing we talk a lot about. The income when I see patients and I go to the ER and I'm up all night, that's active income. I'm working for that. But passive income, that's income that's coming to you. Maybe you set up a deal, but that's income that's just coming to you without you physically having to be there to make it happen. So what are my income sources? And we talked about the first one, which was the practice. And that was the spreadsheet that I told you about. And that consists of both the active and passive income. It's my clinical productivity, and that's all those additional profit centers that I'm involved with. I am an owner in 2 surgery centers. And for whatever reason right now, the facility fees are very good in New Jersey. So by being an owner in these surgery centers, I can reap a profit by being part of these things. So the facility is owned by the health system, it's owned by a management company, and it's owned by physicians. And by being an owner in 2 of those has been a nice boost to my income. And that's something that, a family medicine physician per se would not be able to participate in. Whether this is right or wrong, I'm not going to go into that. I'm going to just tell you, kind of what ends up, being in the different buckets of my yearly compensation. I'm a partial owner in 5 buildings. In 3 of these buildings, the practice is a tenant, and that's a no-brainer, right? Because you're basically renting the building to yourself. So that's the safest tenant that there is. And additionally, and my partners and I are all extremely good friends. We kind of invest together, and then we've also gone into 2 different buildings that we own. I was an angel investor in an implant company, and then I did some design work with them, and that is returned a nice profit. I was an early investor in a bank, and just some of these things come up, and being in the right place at the right time and listening to these deals has been very financially rewarding for me. So this came up, and they were looking for early investors, and we really did our due diligence in this, and this ended up doing extremely well, and then being sold to a larger entity and helped my overall financial portfolio. And then the co-management company, this is something we do with the hospital, and being a part of that gives us a nice dividend a year as well. So, the summary on this is that income comes from a lot of different ways. It's not just, taking care of patients, and being open to these ideas and looking for these other streams of income can really change your financial position. And when I tell you that, participating, let's say, in scholarship, which is something I really, really enjoy, isn't monetized, it's okay, because of all these other things that are happening behind the scenes that let me do something I really love. So switching gears a little bit here on the administrative side, and this is really fun. So I like business. I like figuring out how things work. I like talking to my employees. I like trying to make things better. So anybody that kind of has that kind of business acumen or interest, this is something that's available to you. And it was kind of cool that we switched around in the beginning. And then my partners came to me about 6 months ago and asked me to do this again. And this is really, really fun stuff. This has taken up an enormous amount of my time, but I'm really, really proud of what we're doing and where we're going. And, you know, the fun thing too is, you know, when you're in a place like this, you can kind of shape the policy and kind of shape the direction and the feel of the organization. And that's neat. So the managing partner or the president of our group oversees the entire company. There are a lot of periodic meetings with different administrators and different teams. There are a lot of emails, and I probably go through, you know, around 200 emails a day and send, you know, 70 to 80 emails myself. And then it comprises all of these different things. And, you know, on Sunday night, I'll be reading up on, you know, different parts of accounting or networking, because I really have to understand how all these pieces fit together. And, you know, my role is to kind of, you know, understand the larger, you know, way that everything fits together, because I know my IT guy is going to say X, or, you know, the legal guys are going to say something else, and to kind of be that common voice that puts it together. So you can see it's accounting, legal, HR, all the way down through hospital relations. Strategy and growth is really kind of fun, and looking, you know, how we can bring new physicians on and new areas that we can, you know, have patients utilize our services. And then to top it all off, doing a merger is really, really crazy, because you have to kind of look at what they do and figure out best practices and keep everybody happy and feel like they're a part of it. And then scholarship, that's kind of the final component of, you know, that makes up my work week. As I mentioned, it's often non-monetized. It takes up a significant amount of time. So I saw a couple of the names of people that have worked on research projects with me. And it is, you know, we talk about ideas, but taking the ideas and making a finished product is extremely, extremely time consuming. I like this though. And I think if you get a good team of people and you work well together, and you can deliver a finished product, it's extremely gratifying. And if it's something that, you know, goes on to get accepted and other peers find your work valuable. And I think that's really, really some of the most proudest moments are some of the papers that I put out, because, you know, your world is your audience. And if you have something important to say, it could change the way people practice. And that's pretty neat, because, you know, as busy as I am, I can only see 130 or 140 patients per week. But if you put out good scholarship, you could teach everybody. The education right now at Robert Wood, it's the conference on Monday and Thursday, and I try to attend that as much as I can. I kind of block off that time. We're starting to do journal club, resident lectures. I've done a few of them. Medical student shadowing. I think a couple people even on this Zoom have come to see me in the clinic, and hopefully they've gotten a little understanding about what I do and how I work and what our field is all about. And then just a few times now, I've had a resident with me in the OR, and that's something that I really enjoyed, kind of to teach them my tips and tricks and let them practice their surgical skills. I'm also involved at the national level at the Society of Surgery of the Hand, and I sit on the self-assessment committee. So with a bunch of really, really smart people that meet in Chicago, we write questions all during the year. We have an assignment of X amount a month. And then we meet in Chicago for 2 or 3 days, and we just go through and we hash out these questions and improve the choices and the answers. And I never knew how arduous a process it was, but being part of that is really helped me grow and also make some colleagues across the entire country. And then the research, you know, I'm lucky because I have a full-time research assistant. I saw Amer on the line in the beginning. I don't know if he is, but he is just absolutely incredible. This kind of fell into my lap, that he came and joined us when we were at Rothman, and he's been just so productive and got me interested in it. And then I have a full-time research assistant this year as well, and that's just something that, you know, I pay for. I actually split it with the university guys, but you need that help in order to push some of these projects forward. We've just instituted CareSense, which is an outcome database. You know, you guys would be shocked that, you know, this is still in its infancy, but we're going to collect data on all our patients in terms of patient-reported outcomes, so we can look back 5 years from now at a certain condition and have all the data there to write retrospective reviews. So we're planting the seed for that now. Resident and student participation, I mean, that's the most exciting for me, is if somebody steps up and wants to be a, one of the lead, either the lead or, one of the, first authors or first couple authors on a paper, and watch them grow in terms of their writing skills and the way they think through things. And then right now, we've done a few randomized trials, but as busy as I am, we're kind of focusing a little more on the case reports, literature reviews, and some retrospective things. So, just time and place for different things. And maybe as I back down from the administrative role, hopefully in the next year or so, I can have a little more time for this research. So in summary, you can't do it all as much as you'd like to, and you have to make some choices, and you want to accomplish what you started. You don't want to be that guy that's all over the place and nothing gets finished, because being accountable, I think, sets you apart. And if you can show people that you can deliver, they'll keep coming back and asking you to take on larger and larger roles. I honestly love what I do. I love my family, and I love this job in all the different facets of it. And now I'm in this either hell yes or no. So I will try a couple things, but if it's not great and I don't love it, then very quickly I'm going to move away from it. So this little mantra, hell yes or no, don't do stuff that you don't like, or don't do stuff that you don't think is going to help you, grow in your career, because, you make choices, you be proactive, and find what works for you. You got to make time for your family, your friends, and personal time. You got to take care of yourself. This next one, be present at home. I think that's so important. And, it's something that somebody taught me very early. When you go into a patient's room, I mean, I take half a second and I just stop, and everything else goes out. And when I open that door, it's me and the patient, it's eye contact, it's sitting down. And even if it's 35 seconds, that patient feels like I gave him 100% of my attention. And that's what I try to do when I go home, even if I'm tired, if it's a long day, 100% being present for them. It is easier to assimilate in the culture, even if you're, so, passionate about research. If you're not at a place and you don't join a program that is interested in research, it's going to be very, very hard to buck that. More, I would recommend then, if you want something like that, you go to a place where they're doing it, because it's much easier just to assimilate right into it than have to try to create it. And the journey's rarely a straight line. I mean, it's very rare for people to go from private practice to academics to privademics. But my journey's been a little bit different, and I'm really proud and happy with what I've done. So that's it. That's all I got. And I'm going to open it back up to some more questions.
Wow, that was a great talk. Thank you so much for having that. I feel like, excuse me, a lot of the stuff you talked about, we probably would not have been exposed to until we were in residency. So hopefully a lot of our members were able to also, feel the same way. So yeah, I'm gonna put the attendance sheet in the chat again, and then the floor is open for questions.
Dr. Katt, thank you for sharing your portfolio and all those information. Those are amazing. So I have quite a couple questions on the equity side on stuff. I'm so sorry because I own Biden so much money, so I just gotta ask it.
Sure.
But I saw you have a lot of investment. I'm sure you do a lot of syndication deals, so you have a state tax going back to ownership side and just kind of work on it. So I have a question: is how do you guys determine the equity when it comes to partnership? Because do you guys have like a junior partner a couple of years in, and then different level senior partner?
Yeah.
And what just a follow-up question too on that front. So how do you see the because when you put out the Excel sheet, I see it's mostly based on RVU, and as we see now, I don't think there's any going back after the HSS paper last year on the volume-based healthcare. You see them through surgery, they were saving 25 million in 5 years. So the conversation is going to switch to volume-based healthcare. How does that is going to impact you or like your group's structure as well as like in the future for us? I'm sorry, that's a lot of questions, but I'm poor. So
No, those are great questions. And I think I would love to see more value-based healthcare because I think it's so important. Because we want to look at quality and we want to look at cost. And I think we're kind of giving that lip service, and and the government is making a push for it, but putting into practice, I've yet to see it. And like I said, with these bundled payments and things, they're just scratching the surface. I know for, some of the primary care guys, they give them X amount of money to cover a certain number of lives. I don't see that happening with orthopedics. I might be naive, but I just see fee for service, being the main way we get paid for the foreseeable future. That's not to say we shouldn't start thinking about a valued care. And we have, physicians and administrators that are constantly looking at best practices for these bundles, and we're preparing for it. But I just think too many of the things we get don't lend themselves to kind of fitting into a bundle. They've even tried like a low back pain bundle, and it's a mess right now. So fee for service is here for the foreseeable future. The partnership structure, and again, 10 different practices, you're going to get 10 different things. We don't have a junior partner. So you are eligible for partner 2 years and any portion of the year until January 1st of the following year. So for most people, it's 2 years and, 4 months if they, went straight through. And after 2 years and 4 months, you buy into the practice. The buy-in's low. You get half the ancillary distribution for the year, and we consider that your buy-in on the ancillaries. And then after that first year, you're a full partner. And at 2.5 years, you have just as much of a vote as I do, who's been here 15 years. And the whole thing is that we want young people to come in. That's the future of this thing. It's not about the old guys taking advantage of the young ones.
Thank you so much. That was amazing information. Really appreciate it.
And Dr. Katt, just a quick follow-up about that, like the partnership setup. I don't know, did you say that you had to be like a surgeon specifically to be a partner? Like say some of the other physicians you have there, are they like PM&R physicians or maybe like family medicine with sports fellowships?
Yeah, that's a good question. And I think it depends on the group. In our group, we have we have 2 partners who are PM&R. And they actually do pretty well because of the procedures. And again, it's not a right or wrong. It's that, they work hard and the situation and the time that they came, and because of the surgery center, they do very well for the surgery center with their injections and their procedures. So we do have 2 PM&R guys that are partners. Some of our family medicine guys that did sports training afterwards are not partners. But different programs, different places are going to have different things in terms of that. That's just ours. Everybody else is an orthopedic surgeon, though.
Okay, thank you, Dr. Katt. Thanks for clearing that up, and I appreciate the talk. It was very informative.
Hi, thank you for your presentation. That was extremely informative. I wanted to know, like, when did you start to learn about these type of investments, and how far along in your practice? Because I never considered or even heard about being an angel investor, an implant company, and I've considered outside of being a physician in the future is like real estate to make some supplemental income. But it's interesting to see how you can do the same thing within medicine. So I just want to know, how did you learn about this? And I don't know if you mentioned if you have an MBA. Just how did you become business savvy as well?
Yeah, no, that's a great question. I don't have an MBA. I mean, I like to read, and I think one thing that you learn as a in medical school and even in residency, it's how to find information. If you have to prepare for a case and you're tired, and you're like, all right, I can't just start, reading, this, whatever the Greens textbook on this. I need high yield. How am I going to spend my next 40 minutes before I go to bed, preparing as much as I can from the case? So you're going to talk to your friends and your senior residents, and they're going to say, oh, read this article or that, or you're going to get bullet points and notes. And you use that same kind of acumen to say, all right, like, I want to look at this investment, or I want to look at this topic, where do I go for the high yield stuff? And it's not cheating. It's talking to maybe a professional colleague that you're friends with in the field. And you say, hey, look, can I, buy you dinner and, give me an hour of your time just to talk to me about X. And it's amazing how, often people will say yes. I mean, listen, if they say no, I'm okay with it. But like more often than not, they say yes, and they're kind of interested and excited to tell you what they learn. So just picking people's brains and then asking them like where I can get more information. I learned a lot about that. And, obviously I know medicine because I live it every day. So I think I'm a better judge at if something's going to work or if it's not. Now, one of my partners his dad was very big in real estate, and he's doing a lot of real estate on the side. He does a lot of our real estate deals. And, I will say that I kind of ride his coattails, but every one of them has turned out to be very successful. So if you have kind of another interest, like if you know something about real estate and in your free time, you're always looking up Zillow or, thinking about flipping a house or something like that, do it. I mean, why not have that on the side? And then it can only help you with your practice. Maybe you're the real estate guy for the practice. We have somebody that's like super into IT. Great, let them do the IT. And that's kind of the way we make it work. And then also too, I mean, I will tell you that, and I started this presentation. I mean, I grew up in the middle of nowhere and very, modest home, but now like, being a higher earner, like I'm in social situations where these things just come out and they come up, and then I'm constantly being approached like, we need 5 guys to invest in this. And most of the stuff I pass on, but I certainly, take it home and I digest it and look at it and see if it's something that makes sense. And also I'm really good friends with my partners. So, at some of our meetings, we'll not only talk about medicine, but at the end, we'll just say, all right, well, look, these are the investments on the table that, people want us to do or potentially go into, and we'll dissect them and say, all right, we need to get more information on this, or this is something we pass on. I mean, I can't tell you how many people come up and, pitch me ideas like in the room. I mean, it's crazy. I examine their shoulder and they're like, oh, well, we know, you do well financially. So, we have this thing, we want you to come to this dinner or whatever. So we're constantly being bombarded with opportunities and just vetting them and deciding what to follow. It's kind of fun. You're kind of in a neat position. Some of this stuff will come to you.
All right, thank you.
So Dr. Katt, you wear a lot of hats as we saw. So I kind of want to know, like, what do you feel has made you so successful in efficiently managing all sides of, the business, like your investments, your practice? Like, what would you say truly helps you, compartmentalize everything and make sure everything gets done?
Yeah, I mean, I think I'm a tough critic on myself, and I think I'm, constantly looking to see if I can do it better. And when I said, some of this stuff, if I can get rid of it, and you can't get rid of everything because there's some things you can just accept, but very quickly I'll say, hey, look, this isn't working, and I'll get rid of it. Like we had an opportunity to pick up a surgery center on the cheap, which was down south of Long Beach Island. And it was just it made sense financially for us to do it. But the problem was like, we couldn't get people to go down there. So like, yeah, we had this thing, but it was just kind of, bouncing along the bottom. And, we looked at this and then very quickly we said, wait a second, to put this much time into something that's not going to really pay off, let's just move on. And even if it means we take a small loss on it, kind of, pull back and then focus on the next thing that is going to work out well for us. So I think that with my practice too, I think I'm, a little bit harder in terms of, the people that work with me, I think I'll very quickly say, hey, look, this is going to work or this is not going to work, and then make a change. So if something's not where I want it to be, I'm very quick to say nope and reassess. But and then the last point on that, I think, what I said before about, getting the job done. I mean, and that's one compliment I wanted to give you, Allie, is like, get back to people right away. Like, if you say you're going to do it, do it. Like, your word is what it's all about. So like, I mean, there's nothing cool in being late. So like, just be on it and show people you can get the job done, and they will reward you many times over.
Thank you.
I have a question. If we in the future, if we reach out not about medicine but about the business side of it, would it be okay? Because it seems like you did a lot of syndication deal. You probably have a lot of experience in terms of like limited partnership, real estate, like the 1031s and depreciation bonus and all that. Would it be okay if we just reach out to you if that is not
Yeah, I wouldn't say I'm the expert, but I could at least kind of look at it and then point you in the right direction. And then, we have a big deal going down right now at one of our surgery centers, and it's the same kind of thing that, it's kind of crazy. And when I talk about equity, it's like being at the right place at the right time. And, this thing is going to flip and it's going to be, very lucrative. And, I just kind of shake my head that the whole thing's happening. But, if you're not in the game, then, you're not going to be, able to realize the benefit of it.
Right. Thank you so much.
So I just had a question about like the surgery center process, and I guess becoming an owner of the surgery center is is that maybe something where if you're already there practicing and working, then you reach out to the management there, or is that something where, as you mentioned, that other surgery center that you were looking at down by like Long Beach Island, it just comes up?
Yeah, exactly right. And usually, your group that you join will have, in orthopedics, will have an interest in some of these surgery centers. And then, you just kind of say in the beginning is, hey, look, well, I have the potential to buy in and become an owner in this. And usually, if you're going to do cases there and you're going to be part of it, they're going to want you to do cases there, and they'll get you some ownership. And then you say, so-and-so doctor's leaving, I'll buy your ownership. Like you got to look at it and say like, I'm getting 15-18% on my money, I'll go take a loan for X, and another 1% is open, I'll take it. And then all of a sudden you kind of keep increasing your position, and then the thing flips, and then everyone's like, oh my God, how did this guy do so well? It's because you were constantly, increasing your position over time. I mean, it's just kind of being smart and, saying, hey, look, if shares come available, I'd be interested. But yeah, there are a lot of these deals out there, and, it's not, you're not going to retire on it, but it certainly, augments what we do.
Okay, thank you. And then also, I know you had mentioned that like some of the buildings that your practice is in, you own some of those. Was that something where you guys were already in the building previously, and then you like took over the ownership, or was that something where you maybe sought out the property, got ownership, and then maybe moved the practice in there?
We have all of those things. So we have, we found a building in one location that we liked, and we did and again, I'm not the real estate guy. I just kind of put up the money for it. But people, really vetted the area and looked at the traffic flow and, looked at the price of it and looked at kind of the layout of how we could redesign it for an orthopedic office. And we did that and bought that building. We're building a building right now in Freehold, so that's a whole nother project. And then, this is kind of crazy, but we actually have a 2-floor building, and we got a long-term lease on the first floor. So we had the thing leased, and then now we're going to take the second floor, and it's just going to turn right over into being profitable day one. So, and then we have. The other one is a complex that we basically took over the whole complex, and it's kind of crazy. I mean, like, you guys probably have friends that are in like private equity and stuff like that, but it's crazy that you can own something tangible that you look at and say, oh my God, this is a real thing. This is real brick and mortar without putting a whole lot of money down. You do the math on that and say, okay, well, this is what it's going to cost on the mortgage and on the taxes, and this is what the rent costs. Some guy figures it out for you, and then for a very small amount down, now you just have a situation that's just turning, cash every quarter.
Oh wow, that's amazing.
It's almost silly, and again, I don't want to distract it from what I do on a day-to-day basis, but it sure is nice that all these other things are hitting at the same time.
Yeah, thanks for explaining. That makes a lot of sense, because I was just wondering, since you guys have some of the PT offices within the building, how you guys kind of scope out what locations you want. So thanks for explaining that.
Yep. And then now we're continuing to kind of reassess positions. We have a building in Red Bank that we're looking to move. We're getting larger, so we can hire more consultants that are really understand market positioning and some of that kind of stuff to kind of help us grow into the future. So instead of just, oh, this sounds pretty cool with where you start, now it's becoming a little more sophisticated. Peter, you've been quiet for an hour and 45 minutes.
It's a lot to take in. This is definitely, I thought initially, I saw that they combined the two groups and that this was going to be like a joint talk. I thought it was going to be more clinically related, but this kind of took me by surprise, a good surprise though. So it was very fascinating, but I'm not well versed in any of this. So I'm just kind of trying to take it all in right now.
Well, at least I thought to give you guys a little introduction into, how what you're doing translates into, real world dollars.
Dr. Katt, at what point in your medical career, was it residency or after, when you were already in private practice, did you see this kind of business and ownership component? When did you realize that that's something you wanted to pursue and that's something that you were good at, more or less?
Honestly, I just kind of fell into it. I think it's just being curious, and I'm kind of curious about everything. So I was like, wait a second, well, why is this guy doing this and that guy doing that? And, it just kind of, I kind of built on it as we went along. And I don't know, the practice management, I don't know, I kind of, a lot of people kind of run away from that, but I'm very into the entire process. I think I'm a very good doctor. I think I take good care of patients. But if the person at the front desk doesn't greet them appropriately, if they don't, have a clean waiting room, I mean, when you look and go, Google reviews and stuff like that, it's not about the doctor, where they went to school or, their medical care. They're assuming that's going to be good. It's, what was the waiting room like? Was I able to get an appointment quickly? All this other stuff that's wrapped around medicine that we don't talk about. I mean, that's so much of, what our practice is. And I kind of, put a lot of emphasis on it, but it's the talking to the family afterwards. It's the, the bill is legible. I mean, that just gets a lot of lip service. But I think, when you think of this as a business, you really differentiate yourself if you can kind of focus on those things.
Do you feel like you've lost control to a degree of that as your private practice has grown into NJ Ortho and all that? I mean, I know that you have leadership roles within that.
Yeah, I think that's true. And again, I don't know if it's necessarily, the color of the carpet, but I think it's that you can just kind of push forward that these things are valued and these things are important. And it might not be exactly what you want, but as long as we're talking about it and, investing time into it, then it's going to be okay. And that's kind of what I continue to fight for, because the whole process of medicine, I think, gets kind of pushed aside.
I was wondering if you could speak to how you got into the medical device company and designing for that, and if that's something we're interested in maybe in the future, when would kind of be a good idea to start making those connections.
Yeah. So that's kind of an interesting place to live. And I will tell you that when we're talking about like income and stuff, a lot of the guys in academics, and when I say guys, I mean, physicians in academics, they have relationships with implant vendors. And that was one thing. It's like, I'm still doing the same exact surgery, but then when I became part of Rothman, like 2 different implant companies are like, oh, whatever, we heard about you, and, we want you to come out to our headquarters, and we want to get a contract with you so you can start doing some speaking engagements, and we want you to be on our design team. And I'm like, I'm the same guy. 6 months ago, like nobody's doing that. But now that, you put this label on you, suddenly people become interested. So having affiliations with, certain, educational institutions allows that kind of thing to happen. And it's, again, I think different strokes for different folks. You have some guys that are, consultants for 7 different companies and they're running around the country. Like for me, I just never did it. I was going to go out somewhere, and then COVID came and it kind of fell by the wayside. So it's an option. I don't think it's as lucrative as it may sound. It sounds kind of cool, right? I'm a design consultant, or I'm a educational consultant for X, but it usually means a weekend away from your family and traveling somewhere, and pluses and minuses to that. But in terms of the implant company, and again, a lot of this is just connections. It was a group out of Philly Hand, and I knew some of those guys just from doing past projects, and they called me and they said, hey, look, we're looking to get this thing off the ground. Would you be willing to be a part of it? And, again, it goes back to what I mean, I knew the area and I knew the space of hand surgery, and I said, yeah, this thing is going to work, likely going to work. And then we started having some design meetings with some engineers, and that was really cool. Something I didn't know a whole lot about. And then the business side of, taking kind of a startup forward. And it was just a neat experience. But it turned out to me that the company was kind of doing okay. And then I kind of saw the time point to get out, and then I got out of that investment. Probably at the right time or near the right time. But I think having connections, being around smart people, having curious conversations. I'm not the guy, and again, pluses and minuses, but I'm not the guy that just kind of hangs out and, shoots the breeze. Like, I want to get into it. I want to I think I'm pretty intense and I scare a lot of people off. But if you can hang, I will, go 4 hours and I'm going to find out every single thing you do, about your hedge fund job, and then I'm going to kind of, synthesize that, read about it, and really understand it. So I think, being curious and putting yourself in those situations, they just kind of present themselves to you.
Okay, thank you for that answer.
So I have a more kind of basic and on the other end of the spectrum, aside from business, more about what you do when you're in surgery. So, you compared it to the most diverse, and I feel like we were able to see that from the cases that you presented. But that being said, I just kind of wanted to know roughly, do you do most of your surgeries arthroscopically? Is it open? And what kind of piques your interest the most when you're doing, these types of surgeries? So what do you like performing the most?
Yeah, that's a good question. And, I like the unique stuff. And that's one place where, private practice and kind of what I enjoy in terms of the surgery don't always go well together, because I do a lot of routine hand surgery. I mean, common things occur commonly. So I see a lot of carpal tunnel, trigger finger, arthritis of the thumb, common fractures. I mean, those are most of the things that I do in the operating room. But when I get called, from one of my partners to do a radial nerve dissection or tendon transfers or, bigger, complicated things. I mean, those are the ones I really like. But I don't do a ton of them just being in private practice. But also with hand surgery, a lot of these mangled hands, they come in at inopportune times. So you kind of have to balance the, the time away from family and versus, kind of the more routine things. But I probably have the most diverse practice of anybody in our group. And it's funny you said that, because I pulled out tomorrow's schedule, right? So tomorrow I have open reduction, internal fixation, right wrist. That'd be a volar plate. A right thumb carpal metacarpal arthroplasty. So I'm going to recreate a CMC joint on a patient with arthritis. Right ulnar nerve release and transposition. So that's some nerve work. A left distal biceps repair on a 49-year-old male that lifted a dresser. Another right ulnar nerve release and transposition. A bilateral endoscopic carpal tunnel release. So I do my carpal tunnels through scope. That's probably the most common operation I do. I probably do, I don't know, maybe 150 to 175 of those carpal tunnels a year. Excision ganglion cyst right wrist and excision cyst long digit. So that's my operative day tomorrow. That's a kind of a standard, hand surgery day. And then the bigger fractures and things would be like, then I would go to the hospital at the end of the day and, take care of a shoulder, take care of an elbow, something like that, where maybe they were admitted the night before.
Mm-hmm. And then when you're on call, like, you're a hand and upper extremity specialist, right? But it's general call. Would you ever be expected to then take on like a spine case, or is that something you kind of just leave?
No.
Yeah.
Right. So, and that's one of those things we always go through. So we all took general orthopedic call, but as you get further away from certain things, there's just some stuff that you probably shouldn't be operating on. And Robert Wood is really, really good because the trauma program is excellent, and you get a lot of hands-on stuff. But we've had guys that have come in that didn't have a very heavy trauma rotation, and they're just not comfortable even with the basic trauma cases. So most of the trauma cases I do, honestly, a lot of the people don't like the hand and upper extremity stuff. So I kind of do double duty. So I'll do all the regular trauma, and then I'll take care of a lot of the hand and upper extremity stuff in addition, because they'll ask me and I'll just take it on and find a way to do it. But we have two spine guys at Brielle, and they both take spine trauma call at Jersey Shore. So they are not on the general orthopedic rotation. But at Rothman, the hand guys just did hand call. So they didn't do any orthopedic call. So it kind of depends on the hospital. It depends on the practice. But spine is kind of its own beast. I mean, spine is one thing, like, unless you do a spine fellowship, you're not doing spine. You participate as a resident, but that is completely different animal. And I think hand's the same way. I mean, aside from some very basic hand stuff, that's all getting sent my way.
Probably for the best too.
Yeah, and then like peds, I mean, like, one of the common ones is those pediatric supracondylar fractures. And when I first started practice, I was doing the pediatric supracondylar fractures. And then like 4 or 5 years in, I'm like, why am I doing this? We have a great pediatric group that goes, at the time, McPartland's group went to Jersey Shore. And, obviously I know those guys well. Why am I doing this? I mean, I'm stressing about it. It's not only the case, but it's going to be a couple years down the line. If there's something not right with growth, get that to the guy that does these all the time and can handle the complicated stuff. So, some of the supracondylar ped stuff that gets sent away.
Hi, Dr. Katt. I had a question as well. Could you speak a little bit about when you felt, or at what point in your career you felt that your income stream as a physician was enough to justify or to alleviate the risk of making larger investments?
I think that's a great question. And I would say probably very early on. I mean, I am not a materialistic person. And, the opportunity, the way I got into my first surgery center, there was an older guy that needed money, and someone said it was for divorce or something, and I don't know the specifics, but he needed money and he needed to sell shares in order to generate cash. And he said, these are up. And then one of my partners said, oh, this would be, great for you to get some share ownership. I just come to town, and I actually went around to different banks, and I mean the percentage rate was ridiculous. Like they say, like with a credit card, like 18% or whatever, but you're never going to pay that. You're going to pay off your balance. Like I remember I took a very high percentage rate. My partners got me a little bit lower because it was the bank that we did our corporate banking with. But I took a really high rate, but I looked at what the return was at the surgery center, and I had that loan paid off within about 16 months. So I was just making smart decisions like right off the bat. And that was like the first one I really did, because before that, you didn't have any money, as a resident, as a fellow, you're just kind of getting by.
Thank you so much.
Yeah. And I also got lucky. And a lot of times it's luck too, but I got lucky on my townhouse when I was a resident, and that told me the power of passive income. So we had friends that were in real estate, and they said, well, you're going to be there for 5 years. You don't know what's going to happen after that. And they said 5 years is kind of that borderline term in terms of, does it make sense to own or does it make sense to rent? And the years were 1999 to 2004. And for whatever reason, housing just went up, up, and up. And I doubled my money. So we bought it for, I think, 120. I sold it for 250. And I there was I can't even remember the name of the company, but it was, you sold it by yourself for like 2%, because to me, like 6% seems ridiculous to pay a realtor. And I can't remember the name of this company. And I think it was called Foxtons. I think it's probably gone away because they probably realized they couldn't make a profit at 2%. But the market was so hot on these townhouses that I sold it in a weekend, paid 2%. When it was all said and done, I made more money on the sale of that townhouse, and we lived there for 5 years, than I did my 5 years of residency, killing myself, taking call every third night. And I said, wait a second, if I can make this much money doing this one flip, and I obviously got lucky, and that was not my intention, but there's a big difference between active and passive income. And then it kind of, made a little thing go off in my head to say, hey, look for these opportunities down the line. And I always do that now.
Dr. Katt, given your scholarship interest, and also now how you kind of worked your way into private practice, do you think like the privademics dynamic is kind of the best of both worlds, where you're able to get that, like that personal professional interest that you have in scholarship, while also pursuing your business interest and having more of a control into your practice and all of that? Or I guess in retrospect or in hindsight, would you have made any other decision knowing what you know now?
Yeah, and I cannot. I think if I didn't do private practice, I would have missed a huge opportunity, just for personal growth, but also from the financial aspects of things. And then, the ability to be an owner. So I think the control that you get from that is just awesome. So I really like private practice, but I also like the teaching stuff. And you just have to say, like, at Rothman, it was, you did it because you liked it, but you also did it because you were going to get more money. And now it's kind of like, I have to say, this is still something that's important. And even though I'm not getting paid for it, I want this to be a part of who I am. And again, it's a little easier as I go farther down the line, I can kind of choose how I want to spend my time now. And this is what I want to do right now. It might change in 5 years. I don't know. But right now, I think we got a lot of room to run.
Of course, thank you.
And I think honestly too, like as you start to look around, and I don't know all the places that well, but more and more of these guys that are doing the teaching are saying, wait a second, I want that too. I don't want to be controlled by the university or the medical center, but we have something to offer to residents and medical students or what have you. So I think you're going to see a lot more of this privademic become commonplace.
Thank you.
All right, so we're a little over 2 hours. So I feel like this event was able to, really educate a lot of people on some extremely important topics and something that we're gonna, look back at going forward. So thank you, Dr. Katt, for giving such a great presentation. I was gonna ask if it would be okay to, give some of the members your contact information just in case they have any other questions. And then we have this recorded, so I'll send that to the members as well. And yeah, with that being said, thank you so much, Dr. Katt, and for everyone who's still on the call. We really appreciate it, and we wish you all good night.
All right. Thanks, Sally. Thanks for the opportunity, guys.
Thanks, Dr. Katt.
Email me anytime. All right. See ya.